Hi, everyone, and welcome back for week 4 of the Implementation of Science reading course. Again, my name is Dennis Lee, and today I will be joined by Miriam Rafferty in presenting about the outcomes of implementation. Without further ado, we are going to hop in and get started. So at the beginning of the course, we said that our course in total is designed to address a number of D&I competencies. And we decided that moving forward, we want to cover or list out at least the specific competencies that will be addressed by this and partially addressed by this presentation. I'm not going to read through them, but the list is here for you to peruse when you get the slides. On our agenda today, we're going to be conceptualizing implementation outcomes and then talking about identifying and measuring them. We'll have a specific focus on how outcomes relate to equity, and then Miriam will provide an example from her work before we hop into discussion groups. So today we are reaching the end of the line in terms of the basic building blocks of implementation research study. To recap, we've talked in the past about how we center on a thing that needs to be implemented and how implementation research is about examining how to help other people do that thing. In week 2, we talked about the determinants, which are the conditions that either need to be decreased or removed in the case of barriers, or leveraged or put in place in the case of facilitators. And our little subway map that we're all familiar with showed that the first stop of an IR study is to understand this context, to understand these determinants. Then the last session, we took the next stop on the subway line, which was to design implementation strategies. And these are the actions that we do to help other people do the thing. These actions are frequently designed to specifically change those contextual conditions or the determinants from before. And so today, the final stop on the subway map is to test implementation strategies. And to test implementation strategies, we need indicators to tell us how well things are going or how much change there has been due to those strategies, which brings us to the topic of implementation and service outcomes. So these descriptions come straight from your Proctor reading. Implementation outcomes are the effects of deliberate and purposive actions to implement new treatments, practices, and services. And implementation outcomes serve 3 functions, and these functions are not mutually exclusive. So implementation outcomes could be proximal indicators of implementation processes. Something has to be feasible before you can adopt it, and then once you adopt it, then you implement it, and once you implement it, then you sustain it. So you can use these kind of as a checklist or milestones in the process of implementing something. Implementation outcomes can also be indicators of implementation success, and by that we mean these could be the primary outcome for your study. So the thing reached 80% of eligible patients. That could be the primary finding of your study. And then the third function is that they are intermediate to service system and clinical outcomes. Similar to that first point, you must implement the thing before you can assess its service quality, and you must reach patients before you can have any clinical effect on them. So there's a kind of a moderating effect along the way. Kind of thinking about that from a visual standpoint, the definition of implementation outcomes, these are the effects of strategies. So we're familiar with the implementation research logic model at this point. This bottom row over here, the innovation thing, the mechanisms, and then the patient clinical outcomes, these are the effects of the thing, i.e. your effectiveness outcomes. So in accordance with that, then the top row, the implementation strategies, the implementation mechanisms, and then the outcomes, implementation outcomes, are the effects of the implementation strategies in a pure implementation study. This is a pure effectiveness study. This is a pure implementation study. And of course, we had a reading on hybrid studies. Hybrid studies measure both in the same study. So you will have outcomes related to implementation and strategies, and you'll have outcomes related to the effects of the thing. Hybrid type 1s will have more effectiveness outcomes in the study. Hybrid type 3s will have more implementation outcomes in the study. I think that the key thing to remember is that both sets of outcomes, they always exist in any study that you're doing. You might just not be measuring them in your study. So a pure effectiveness study they have implementation outcomes in the background, and a pure implementation study has effectiveness outcomes in the background. You just are not measuring them. Some other key points around hybrid studies to take into consideration. Another way I like to think about it is this balancing act. A hybrid type 1 really emphasizes the effectiveness outcomes over the implementation outcomes. A hybrid 2 puts equal weight on what you're measuring in that study, and a hybrid type 3 puts a lot of weight on the implementation outcomes, but still has a little bit of the effectiveness outcomes in there. We wanted to point you to 2 papers that have been published since that Curran 2012 article, one by Sarah Landis in 2019, and more recently another paper by Curran in 2022, that talk about kind of the evolving thinking around implementation, around hybrid effectiveness implementation studies. And some of the thoughts around that include a focus or kind of a restatement that the hybrid typology really focuses only on the outcomes of interest. They are not a research design in and of themselves. So if you say like, oh, my research design is a hybrid type 1, that actually doesn't mean very much, because it could be an observational study, it could be a clinical trial. So we try in both of these papers, they kind of iterated the point of like not calling it a hybrid design. You can call it a hybrid study though. They also said hybrids don't have to be trials themselves, even though the original paper focused a lot on trials. These new papers talk about how research designs are not inherently linked to the trials, but some designs make more sense for each type than others. Hybrid type 1, since it's focused on effectiveness, often favors more individual level randomization or observation. Hybrid type 3s, because they're at the systems level, tends to be more cluster designs or kind of bigger level things than the individual. Another thing to keep in mind is that the typology is shorthand for a continuum. We say there's a 1, 2, and 3, but in reality, there could be like 1.5s, 2.5s, things along this continuum, depending on how much weight you're giving the outcomes. However, that doesn't make that's not helpful when you're trying to communicate with someone. So you end up with this 1, 2, and 3. And sometimes it might feel like a little bit of a square peg in a round hole, but keeping in mind that this really is a continuum. And the last thought to mention is that these authors really think that type 1s and type 3s should be much more routine. These should be a very commonplace because we want to speed up the pace of research. And type 2s do require a fail-safe, meaning that because you're testing both at the same time, if the implementation fails, you don't want to jeopardize your effectiveness outcome as well, the effectiveness half of your study. So there are a lot of reasons to think about the outcomes early. The subways kind of puts it the last of the 3 steps in the green, but I actually find it really helpful to think about them really early, because knowing where you're going first knowing where you're going is the first step of getting there. And so thinking about outcomes early can help you recognize the potential impact of your work as well as where the gaps are. So if you have an evidence-based innovation, and you're asking questions about where it can be adopted, how can you deliver it with fidelity, will the program reach its intended population, and will the program sustain it over time? These are essentially outcomes along the way to get to a public health impact. Now, if you can imagine, if each of these only exist at a 50% threshold, or you only get to 50% adoption, 50% fidelity, 50% reach, when you multiply that together, you end up with only a 6% population benefit. So there's a very strong moderation effect happening with these outcomes. And by thinking about outcomes early, you can identify where the biggest gap is going to be and where the biggest impact your research could add. Thinking about outcomes early helps you think at the systems level. So I believe we might have seen this figure in the first week, but in effectiveness research, we are really focusing on these the effects of the clinical intervention with the service delivery system in the background. But implementation really focuses on the systems level. And for folks who are trained as clinical, like RCT scientists, sometimes that's hard to do. So thinking about where these outcomes are measured and where they sit can help one reframe their thinking to be kind of at the higher systems level. Thinking about outcomes early helps you not get stuck in pre-implementation and formative research. And this is, I think, something that we see a lot for folks who are newer to implementation research. They do a lot of work in this understanding context and determinants, and then don't make the leap to the next step of getting to strategies. So if you're focusing always on implementation outcomes, that will push you towards getting to testing and evaluating strategies. We kind of talked about this with hybrids already, but thinking about outcomes early helps you select the appropriate study design for your research. If your focus really is on taking something to scale, and thinking about the outcomes that are related to that, that's probably going to mean a qualitative study is not the most appropriate design for that. So keeping in mind where your targets are will get you to pick the appropriate methods. And then finally, thinking about outcomes early really helps you engage your partners in implementation research, especially when they get lost in the jargon very easily. Implementation partners, community partners are very familiar with process evaluation. They understand quality improvement inherently. And by talking about implementation research as it relates to those things, and because all of these kind of overlapping methods, excuse me, involve understanding context that influences outcomes and doing and identifying strategies to improve those outcomes. So I have found in my own work that focusing on outcomes in this way helps talk about implementation research to partners. So we're going to transition quickly to talking about identifying and measuring outcomes. We don't have a lot of time to go super in depth today, but we want to provide you a lot of resources that you can follow up with on your own time. So thinking about our kind of taxonomy of implementation frameworks, outcomes are going to be all the way here on the right, called evaluation frameworks. And the two main ones used in the field are RE-AIM, which stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance, and the Implementation Outcomes Model, or the Proctor Model. Both of these were readings for this week. The key points for you all to take away from this particular slide is that there is considerable overlap between the models. So you really can't go wrong in choosing either one. And oftentimes folks will supplement one thing, the construct from one into the other. And then that not all outcomes are appropriate or needed in all studies. So you can have an implementation study that focuses just on 2 or 3 of these outcomes. You don't have to hit all of them at the same time. Similar to how you don't have to study all determinants in a single study. There's a really lovely paper from 2013 by Kessler called "What Does It Mean to Employ the RE-AIM Model?" And they really go through very step by step how to operationalize each of the domains within RE-AIM. So for example, in adoption, I don't know if you can see my mouse, but the adoption level setting, they say, if you are measuring adoption at a setting level, you want to measure setting exclusions, either the percentage or the regions, percentage of settings approached to participate, characteristics of that setting, of settings that do participate, and compare it to settings that don't participate. And you use qualitative methods to kind of understand adoption at a little bit more at the mechanistic level. And then in this paper, they also talked about fully developed use. So you can pick, A, B, C, or D to measure adoption at the setting level in your study. But if you want full development use, then you must have both B and C and at least one other A or D. So this paper provides a lot of guidance for anyone using RE-AIM in their work. Kind of pulling that out into a paper, kind of a table format. In 2018, Glasgow and Estabrooks kind of came up with kind of pragmatic definitions for the RE-AIM constructs. So adoption really is about where was the program or policy applied and to whom was it applied. And then the operationalization that you see on the right-hand side kind of mirrors what was in that Kessler article. Implementation is about how consistent something was delivered, how it was adapted, how much or what did it cost, and why did those results come about, so focusing on the mechanisms. Reach is about who it was intended to benefit and who actually participated or got exposed to the thing. Effectiveness, we all are pretty familiar with, did it work? Did the thing work? And then maintenance is kind of when will it become operational? How long will the delivery be sustained level, and how long will the effectiveness results be sustained in the individual level. So there's a lot of text on this page, but we put this in here for you to reference as needed. Similarly, the Proctor paper had a very lovely table, very useful table in there. I encourage you to go back to that often as you're operationalizing constructs for your work. I think some big takeaways are that are about the when. You measure outcomes at different stages of implementation. So acceptability, appropriateness, and feasibility are probably the most important during pre-implementation when you're trying to determine whether a thing is even good for a particular setting. And we often think about acceptability and these things from a consumer perspective, but in implementation research, we want to make sure that we get the implementers' views on these as well. And then as you move through different stages of implementation research, you start to pull in more of these implementation outcomes. So this is a table that you all can come back to as well. Just a very quick note about service outcomes, because we won't talk about them very much. These come from the Institute of Medicine Standards of Care, and they're really focused about the quality of care from either the system or the recipient's perspective. From the system, you can measure things like the safety of delivery, but you really need some recipient's perspectives to talk about patient-centeredness. And one thing to think about for service outcomes is that some of them can be derived from implementation outcomes in combination with things like time and cost. So for example, efficiency is about how much you're delivering things divided by how much it's costing. Equity can be operationalized, and Miriam will talk about this in a bit. Who are you reaching and who are you not reaching? And timeliness is about, again, service delivery, but the denominator's time. Are you delivering and turning out your thing in a timely fashion? This last table I also won't go into, but basically this says Russ Glasgow did a crosswalk of Proctor and Re-AIM, and this just shows that there's so much overlap of these two models, so we really can't go wrong with either one. Now I'm going to turn it over to Miriam to talk about equity.
Okay, and actually, Dennis, I think I can share my screen if you, let me just put it up. Okay, you should be seeing the good view, right? Okay.
Yep.
So yes, as Dennis said, I'm going to talk a little bit about equity and outcomes, and then talk a little bit about one of my projects. So there was a really nice paper that came out, which I think is actually one of our papers that we'll talk about in the sustainability talk, or that you'll have for reading the Sustainability Week, that talks about how sustainability and equity fit within the Re-AIM model explicitly. And what you see here is I put health equity in the yellow section, which means that it's really driving, along with costs and the context being so dynamic, it's driving how we view our outcomes, and that sustainability needs to be something that we're thinking about continuously. So cost and equity are driving forces of anything that we're implementing. Equity specifically requires initial attention and also ongoing attention and adaptations. So it's just something that you should never not think about, and that you can think about equity within each one of the Re-AIM domains. Dennis shared this paper by Kessler and colleagues, and I just wanted to highlight a couple of things. C and D are in this one. I know it's really small to read, but equity has always been a part of Re-AIM. So just because they've been putting it in these kind of 2020 articles more explicitly, it has always been there. That, in it, for an example here with the adoption, that the characteristics of the settings participating. So in rehabilitation medicine, I see a lot of implementation and knowledge translation research coming out of academic medical centers and tertiary care centers like Shirley Ryan Ability Lab and Northwestern, and, name any big medical center. But there's not a lot of rehab out there in federally qualified health centers. And so we already have to know that just the place where we are trying to implement is creating and perpetuating inequities in the system. And then what about our staff who are doing it? again, if you look at the staffing at academic medical centers, it is not representative of the people that we serve, and it is certainly not representative of the population as a whole. And so you might want to just even look within your staff that at your site, the types of education that they have, their race and ethnicity, especially if that's relevant to the outcomes that you're trying to achieve. And in the case of implementation, the example is the fidelity, for example, implemented accurately, or is your implementation processes being done with fidelity in all participants, in all settings, or is there anything about any of the subgroups or contexts that is also inequitable? So it's just something that you can think about throughout the re-aim. There's also a really nice article by Anna Baumann and her colleague Kabasa. And this is in our list to read on, I think it's research design and day. So again, these are articles that you will see throughout the course, but we wanted to bring them in here because of how much they relate to outcomes. And so she gave a really nice summary of 5 key points related to equity that we should consider. And one of them is to use an equity lens. This is the bottom row, use an equity lens for implementation outcomes. She also highlights the first row is focusing on reach from the very beginning. And I think reach is one of the equity, it's one of the outcomes that equity plays a really large role in. So it's just a really nice summary of how we can look at equity throughout. So in my example, and actually I'll go back to Baumann one other time, and that's to say that this past week, she gave a really nice talk at the Prevention Science Methodology Group, or PSMG. And the lecture is not online yet, but it will be online soon. So if you do not already sign up to receive the virtual grand rounds from PSMG, you can just like Google PSMG Northwestern. If you just Google PSMG, you'll end up with some stock. I don't know what that is, but make sure you Google PSMG Northwestern and it'll take you to our page where you can sign up for announcements. She gave a really nice talk about how to look at equity from the lens of being somebody who's still learning it. And so as I present my case, I am going to share some of my equity wins and also equity fails, because I am just learning about how to do that. So if you have any constructive feedback, please feel free to share it, because I'm trying to do more with it. So this is a case of a program that we started here at Shirley Ryan Ability Lab in 2016 called Proactive Physical Therapy for people with early Parkinson's. And I will start with a positionality statement. Again, related to equity, I'm learning about positionality. There are so many parts of my position that I could share with you, but I will share in the context of this physical therapy program. I am a highly educated white woman with highly educated parents and grandparents who have all sought tertiary care easily as they aged. Easily in that they knew who to call, they knew where to get resources, and they knew that it would either be paid for by their insurance or that they could pay for it. And this includes a grandmother with Parkinson's disease. And so that, I think, does influence how I approach my research in this patient population. And so because of that, my knowledge of disparities and the equity challenges with access and reach to providers, including allied health providers, comes from my professional work and rather than my personal life. So the way that I started my study is I use a knowledge translation process model. In this context, knowledge translation and implementation can be used synonymously. There might be small distinctions, but let's just call this an implementation process model. It's called the knowledge to action cycle. And it has you start in the middle with seeing like, what is the evidence supporting what you're doing, determine the no-do gap, and then very similar to the models, theories, and frameworks we've learned about, you need to make sure you look at the barriers and facilitators over here on the left side. And actually, let me make sure I've got my laser pointed on the left side. And then on the right side, we're evaluating our outcomes. So moving very quickly through the first part of this, because I want to focus on outcomes, I will just say that there's a clinical practice guideline supporting what I want to do. We had lots of data to show that we weren't doing it. We weren't doing physical therapy very well early after diagnosis. This is a comparison across a bunch of different centers. Some centers were sending 50% of people with early Parkinson's to PT, and other centers were sending 0% of their patients with early Parkinson's. So there's clearly an opportunity here for improvement. So we looked at the barriers and facilitators, and we did this using the implementation research logic model kind of as we were even developing the implementation research logic model. We were kind of thinking about it in this case. We used CFIR1. So you'll see here the terminology that matches CFIR1. Kind of following what Dennis shared, we wanted to use a hybrid study, not a hybrid design, a hybrid study, although I have now retroactively changed that to study. And our innovation that we were implementing, the thing we were implementing was this delivery model of physical therapy. That mechanism would be to increase exercise and physical activity, which should increase patient outcomes. Now, that's where we started. It ultimately ended up looking a lot more complicated. And you can see here, and I'm sorry this is a little bit fuzzy, the details aren't important, but just when I described this in a grant, see how much space I actually spent on describing the thing. I spent way more time on the thing than on my strategies. And then, for this presentation, skipping over all the implementation stuff, but I wanted to share these 2 yellow boxes are fairly evenly sized. So this was a hybrid type 2 study that we did where we had some implementation outcomes that we were looking at, which were reach, which I'll kind of make, it's kind of analogous to Proctor's penetration, adoption, fidelity, and sustainability. And then in service, we were looking at the effectiveness of our, if we did PT, were the patients actually increasing their exercise, and then our clinical outcomes for the patient. So I kind of boxed these fairly evenly split. We use the REAIM framework. And the outcomes I want to highlight here, this first one that I'm going to highlight is fidelity. And we use chart audits. Chart audits are a really important outcome. They're kind of a part of, in the knowledge to action cycle, they're actually part of kind of monitoring the knowledge use as you go. They're not like a final outcome. It's a formative evaluation as well as a final evaluation. And so in this fidelity chart audit, we were looking at the number of staff who were documenting what they were supposed to document. And we compared some general staff who saw this patient population and our 8 trained staff members. And you can see that the number of people who were documenting what they were supposed to document increased from like 25% to 100%. So we thought that was a win. This would be something, and I've seen some really nice tables that we could, when we could do these chart audits like every 3 months and make sure that we stay at 100%. You might expect to see over time, if you're not reminding people constantly, that it might decrease and then come back up. So fidelity and chart audits are something that you can do repeated measures over time. Let's see what else, anything else to add about fidelity. I think the other thing I'll share is that these chart audits are a really important strategy. They also can be a costly and time-consuming one. So that's just something for everybody to keep in mind as you plan and budget projects. Moving on to REACH. In 2016, that was the first year of our program. And we found that we received referrals for 38 patients with Parkinson's. These were 38 patients that otherwise would not have been referred probably to therapy. So this is in the past were not referred. And this is about 25% of the Northwestern new patients each year. So there's still opportunity, I think, there for improvement. If we think of that graph that I showed at the beginning, we're somewhere between 0 and 50% now. But I'd really like to see it be up at like 75%. And we had 50% of our patients self-reported that they were doing more exercise. And this brought up like a lot of our challenges in measuring our effectiveness in the medical records, because we don't have really good clinical measures of exercise. Most exercise and physical activity studies are done with like where they give everybody a Fitbit, they give people tablets, they do all these things in the studies, but in the clinic, we can't do any of that. So there were a lot of challenges with measuring effectiveness. We looked at adoption, and of the 38 patients who were referred, 28 of them came. So this is kind of like a mixture, I think, between REACH and adoption, but it's the patients who are accepting their referrals. And we learned that one of the barriers was a location barrier, which I will talk to you more about when I present on sustainability. And we did find that our number of physicians who referred to the people with early Parkinson's increased in 2016. And the rate of referrals increased as well. 86% of our newly evaluated patients had the right delivery model, which was an implementation fidelity check. And you saw our numbers from the documentation audits that we were having, 75 to 80%, or 75 to 100% documentation fidelity. And then REACH, I'll talk more about in a few weeks, that those also have increased over time. This program is still alive now, 8 years later. And it grew over time from 2 PTs to 9 PTs, 1 to 4 sites of care, and from like 2 doctors who are referring to us to 11 unique doctors who are referring to the program, and it's spreading to other diagnoses as well. So that was just kind of a way that we operationalized measuring our fidelity and our re-aim outcomes in a really simple kind of direct clinical program. Does anybody have any questions before we move to breakouts for Dennis or I?
I have a small question. In the Proctor model, can you explain how service is different than the clinical and implementation outcomes?
That is a great question. I think of them as kind of being, I think of service outcomes to some extent as being proximal clinical outcomes, that they are, implementation is kind of about the implementation strategies. And then service to me is more of that precursor to the clinical. So in my case, the clinical outcome is the patient's function improves. Well, the patient has to increase their exercise for their function to improve. Like their function's not going to improve magically. So I think of that as being the effective delivery. And other service outcomes include things like efficiency of service delivery. So are patients getting in as fast as they need to? And patient-centeredness, I believe, is there as well. And I will pass it off to Dennis to see if he has anything else to add.
Yeah, and I agree with kind of what you were saying, Miriam. I think about, so clinical outcomes are all about the thing and the effect of the thing. So they're pretty easy to section off. The implementation outcomes are, I agree with what you said, kind of about the effectiveness of the strategy itself. So I think about it as like it's about how the thing is delivered, whereas service is more about quality. How well was that service delivered across the patient populations? I know that's not the most satisfying distinction, but
No,
there is
that's helpful. Thank you, guys. And thanks for your presentation. That was super helpful.
That's something for you all to discuss in your groups.
Really nice comment from Mira as well. That service outcomes kind of evoke QI or evaluation.
Mm-hmm.
Yeah, I work at CCR where we have that kind of intersection between like quality improvement and like program redesign and redevelopment and efficiency of services versus like what the students or the patients are actually experiencing, which would be more clinical.
I think with that, we can probably go into our breakout rooms and continue the discussion.